If a patient says, "I can stop whenever I want, I just don't want to," how do you assess dependence without sounding judgmental?
Cascade presents CASC Exam Masterclass with Dr. Clarke. Opioid dependence.
Hi everyone, I'm Dr. Clarke MRCPsych, and welcome back. Today we're covering a really common but deceptively difficult station, taking a substance use history in an addictions clinic, specifically assessing for opioid dependence. In fact, I had a very similar station in my own CASC exam, so I know exactly why candidates find these consultations challenging. This station can feel uncomfortable because patients are often guarded, ambivalent, or minimizing their use. But the good news is this: if you stay calm, structured, and non-judgmental, this actually becomes a very manageable station to score highly in. Working in addictions taught me some really important principles for approaching these conversations effectively. And in this video, I'll show you exactly how to explore heroin and co-codamol use clearly, identify the core features of dependence, assess physical and psychological risks safely, and build rapport without sounding interrogative. Let's break it down.
You are working in an addictions clinic. Mr. Timothy Tutty, aged 42, presents reporting heroin use alongside over-the-counter co-codamol for chronic pain. Your task is to take a detailed substance use history to determine whether his presentation meets criteria for dependence. Candidates often think, "I just need to ask all the dependence questions." But examiners are actually thinking, can this candidate build rapport, obtain an honest history, and synthesize a coherent picture of dependence safely and empathically? Examiners are not looking for rapid-fire checklist questioning, judgmental language, or focusing only on heroin use. They are looking for structured exploration of substance use, assessment of dependence features, quantification of use, targeted addiction-specific risk assessment, assessing functional impact, and collaborative communication.
Hello Mr. Tutty, I'm Dr. Clarke, and I'm one of the psychiatry doctors in the addictions team. Thanks for coming in today. I understand you've been using heroin and also taking co-codamol for pain, but I'm really interested in hearing things from your perspective. My role today is to build a clear understanding of what's been happening so we can think together about the best support moving forward. This isn't about judging you or catching you out. It's about understanding your experience. Does that sound okay? Sometimes these conversations can feel difficult, especially when the substances are helping you cope in some way. You can take your time, there's no rush. Now I just want to pause the role play for a moment because there's a really important communication principle here that genuinely changes how well these stations go. In addiction psychiatry, the first minute of the consultation is absolutely vital. Many patients with addictions have already experienced a huge amount of judgment, shame, or stigma, sometimes from professionals, sometimes from family, employers, or society more generally. So if we immediately jump into rapid-fire questions like, how much heroin do you take? How often? Are you injecting? Without first building rapport and explaining why we're asking these questions, patients often become guarded very quickly. They may then minimize their use, avoid difficult topics, or emotionally disengage from the consultation altogether. And that's why strong candidates don't approach addiction stations like interrogations. They frame the review collaboratively. They explain, "I'm trying to understand your experience properly so we can think together about the right support for you." That single shift in tone massively improves engagement and disclosure. And examiners really like this approach because it demonstrates trauma-informed, patient-centered practice rather than checklist medicine. Okay, let's go back to the station. Could you tell me in your own words what brought you in today? Can I ask, how did your heroin use first start? What was happening in your life around that time? How has your use changed over time? How long have things been at this level for? So you started using heroin around 3 years ago, and your use has gradually increased in amount and frequency over time.
Instead of asking, "Why are you taking heroin?" try saying, "Can you talk me through how your heroin use first started?"
Could you talk me through what your use looks like at the moment? On a typical day, how much heroin would you use? How often are you using currently? And how do you usually take it? Do you smoke heroin or inject it?
One of the easiest ways to lose marks in addiction stations is failing to quantify use clearly.
Examiners want specifics. Vague descriptions like just a bit, quite a lot, or occasionally make it impossible to assess severity, dependence, or overdose risk.
Have you ever shared needles or other injecting equipment? You mentioned co-codamol as well. What strength are you taking? And roughly how many tablets per day? Has this amount increased over time? Just so I get the full picture, do you use any other substances as well? Do you drink alcohol, smoke cannabis, or use anything else? It sounds like both heroin and co-codamol have gradually become a part of your daily routine, and you're struggling to cut down.
This is the core of the station. Examiners are looking for a coherent picture of impaired control, craving, tolerance, withdrawal, and continued use despite harm.
I'd like to understand how much control you feel you have over your use at the moment. Do you often find yourself thinking about using heroin, or planning your days around it? Do you get strong urges or cravings to use? Do you ever find yourself using more than you intended to? Have you tried to cut down or stop at all? What happened when you tried? When you don't use, how do you tend to feel? Do you get any symptoms like sweating, vomiting, aching, or restlessness? Do you ever use mainly to avoid feeling unwell or going into withdrawal? Have you noticed needing more over time to get the same effect? Has the use continued despite problems it's causing? It sounds like when you try to stop, strong withdrawal symptoms kick in. Then using again helps to relieve that feeling, making it very difficult to break the cycle.
Strong candidates don't just ask dependence questions individually, they synthesize the answers into a coherent picture of opioid dependence in line with ICD criteria. A reflective statement like this tells the examiner that you're not just collecting symptoms, but you understand the cycle of dependence, the patient's experience, and the function that the substance is serving. That's what turns a checklist history into a psychiatric assessment.
I'd like to understand how this has been affecting your day-to-day life now. How has it impacted your work? Have there been any difficulties with reliability, concentration, or safety at work? Can I ask, are you still driving at present? How have your relationships been, like with your family, partners, and friends? Has it caused any financial pressures or difficulties? Have there been any issues with the police at all? Have there been any situations where your drug use has put you or someone else at risk? It sounds like this is beginning to spill over into lots of different parts of your life. Can I ask a bit about your physical health now? Have you ever had any overdoses? Do you have an overdose or naloxone kit at home? Have you had any health problems like abscesses, blood clots, or infections from injecting? Have you ever been tested for things like hepatitis or HIV? Have you ever received any support around safer injecting or harm reduction? How has your general health been? And your sleep and appetite? How is your chronic pain itself at the moment?
Remember that co-codamol misuse may initially begin as legitimate pain treatment before dependence develops.
Substance use can also affect people emotionally as well as physically. In terms of your mood, how have you been feeling in yourself? Have there been any times recently where you felt particularly low or hopeless? Have you had any thoughts about harming yourself at all? It sounds like things have been weighing heavily on you at times as well. Where do you see things at the moment with your drug use? Do you feel it's becoming a problem, or is part of you unsure? Have you tried getting help before? What made you decide to come in today? It sounds like part of you feels the drugs help you cope day to day, but another part of you is starting to worry about where things are heading.
In addiction stations, reflecting ambivalence scores highly because it demonstrates motivational interviewing skills. Strong candidates begin summarising before the station ends. Why? Because summarising demonstrates organisation, active listening, psychiatric formulation, and collaborative communication, all at the same time.
Let me just check I've understood everything properly. You've described how your heroin use started some years ago and has gradually become more regular, alongside increasing use of co-codamol for pain. You've experienced things like needing more to get the same effect, withdrawal symptoms when you tried to stop, and difficulty cutting down. It's also starting to affect other areas of your life, like work, finances, and relationships. Taken together, these are features consistent with opioid dependence. Does that sound like a fair summary to you? Thank you for being so open with me today. I know these conversations aren't easy. What you've shared gives us a really helpful understanding of what's been happening. We can now think together about the safest and most appropriate support moving forward. But before we finish, is there anything important you feel I haven't asked about?
More full CASC station walkthroughs available on Cascade now. This approach demonstrates structured and systematic substance use history taking, explicit assessment of ICD-11 features of opioid dependence, clear quantification and characterization of substance use, safe targeted assessment of drug-related risk, sensitive exploration of co-codamol misuse, empathic non-judgemental communication, and integrated assessment of insight, readiness for change, and motivation. Common pitfalls include failing to quantify heroin use, forgetting co-codamol misuse, missing withdrawal symptoms, not asking about injecting risks, ignoring occupational and social impact, and sounding like an interrogation. Here is your roadmap to success. First, build rapport. Next, explore the timeline of substance use. Quantify current heroin and co-codamol use. Identify dependence features. Explore functional impact. Assess risks and physical harms. Assess insight and readiness for change. Then finish by summarizing clearly and collaboratively.
This station isn't about acting like a detective. It's about helping the patient feel safe enough to speak openly. If you stay calm, structured, and genuinely curious, while clearly identifying dependence features, you will score highly in this station. Try practicing this out loud with a peer, and focus especially on your reflective statements and summaries.
If you're preparing for the CASC exam and found this station helpful, you can find many more stations, tips, model scripts, and timed scenarios on the Cascade app. The platform was developed from my own experience preparing for and passing the CASC exam first time, alongside years of psychiatric experience in the NHS. Cascade is designed to build confidence, structure, and fluency for your real CASC exam. We've also had some really encouraging feedback from trainees using Cascade in their own exam preparation. Click the links in my bio to get started.
If this video helped, then please subscribe to my channel at Dr. VT Clarke and comment below with which station you'd like me to cover next. And remember, slow down, stay collaborative, and approach substance use with curiosity, not judgment.